All right, thank you so much for having me. Um, Morning, everyone. Afternoon, where I am. Today, I was asked to come and do a little bit on, hearing loss and dementia. It's sort of a topic we hear about in the news a lot now. Um, it's probably the most press hearing loss has ever received, this kind of research that started to come out. But what I want to do is kind of walk you through sort of at a basic level, what is hearing loss? How do we get from hearing loss to something like dementia? Some of the recent research linking the two, and then if we treat hearing loss, does it change anything? And then end actually with more practical information and tips and some recent policy work that's happened at the federal level, sort of changing the lay of the land for hearing care. So with that, again, thank you for the sponsors for this supporting this talk. Full disclosures for me, I do have grants from the National Institutes of Health, specifically National Institute on Aging and National Institute for Deafness and Communication Disorders. I no longer serve on the Scientific Advisory Board of Neosensory, but I did serve until 2023, and we are required to disclose that for 3 years post. So I'm not active, but I did serve for a while. And I'm faculty at the Cochlear Center for Hearing and Public Health at Johns Hopkins University as well. I still have an adjunct appointment, which is supported by a private gift from the company Cochlear Inc., which is the largest cochlear implant manufacturer in the world. But I don't talk about cochlear implants and don't use them in my research. So basics here on hearing loss and sort of public health. I think that one thing that most people don't realize is really when we think about hearing loss, the first thing you tend to do is sort of think, well, if you put your hands over your ears, you're sort of simulating hearing loss. It's maybe all things getting quieter. But the reality is, hearing loss is really a clarity issue and not as much of a volume issue. We lose our hearing at different frequencies at different rates. So hearing is kind of difficult to notice because you don't see it, right? We don't see sound. But it would be, for the visual equivalent, be like having the color spectrum and losing the ability to see different colors at different rates. So maybe blue is clear, but green is blurry, red you can't see at all, orange is blurry, yellow's fine, purple's fine. It would make for quite an interesting sort of visual, world. And so with hearing loss, what you're looking at here on the screen is the audiogram. It's the graphical representation of hearing loss. It's what you should get after you do a professional hearing test. As you're going down, we are getting louder in sound. As we go across, we go from low pitch to high pitch, left to right. This audiogram has some different symbols to represent different sounds. And what you kind of see is that a bird is a high pitch, soft sound, whereas a truck is a very loud, low pitch sound. In the middle, you've got the speech banana or speech boomerang, depending on, I guess, if you're in Australia or not. And it's got different parts of speech. And what you might notice is that consonants, like very soft consonants like F, S, the TH, the th sound, those are voiceless consonants. We make those sounds without using our vocal cords. We just use our breath. Whereas vowels, A, E, O, those are sort of guttural. They use your vocal sound cords, and they're sort of louder and lower pitch. Because we lose our hearing loss at different frequencies, it looks like this. You're relatively perhaps, mild or normal through, midway point, 1000 hertz, 2000 hertz. And then we start to lose it. And so in theory with this, you wouldn't hear anything above the line. You would hear things below it. And this would make speech quite unclear, as you could imagine. It would be kind of like if I were to say to you, you should go to the pharmacy before you get to your house, and you had this hearing loss. It would be more like you would go to Army E before you get to your OO, which sounds kind of like a bunch of gibberish. But perhaps if we had some context to this scenario, you could kind of put it together. And so the way I like to think about hearing loss as a clinician even, but in the context of public health, is that hearing is a function of peripheral encoding and central decoding. So your access to sound and how your brain processes that sound signal. And so if you have some hearing loss, and someone said the word Sunday, but you only got a little bit of it, maybe it sounds like unday, your brain receives that unday. And so you might think of it kind of like if you've ever, for those of us who actually, had experienced this, like a radio in your car. Now I think everybody just uses, whatever app on their phone and they're just listening to things. But if you got a bad radio signal, you might start missing little blips and pieces here. And you can sort of make out what it is and you can put up with it, right? Or if you're on a bad cell phone signal. But that's an effort, right? It's an effortful listening process where these sort of rough, haphazard signals require your brain to put in some extra effort to listen. And the cell phone signal concept is something I think we're all relatively familiar with. If you've ever had a conversation, an important conversation on a bad cell phone signal, you know that it is exhausting because you are stressed and you are trying to listen really, really closely and make out all those small pieces. And in a way, that's sort of what hearing loss actually is like when we just operate like that in our everyday lives. With sort of the established concept of how we're going to talk about hearing loss, and this idea of peripheral and central decoding, we measure hearing loss by your access to sound. So it's the peripheral side, right? It's how your ear can access sounds in the environment around you. And when we use that sort of gold standard or criterion standard, as some people call it, test, and we look at the United States, we know, and I think we already sort of knew this at a base level, we knew hearing loss increases with age. But once we really started looking at nationally representative data, I think we realized just how much it increases with age. Once we get to the age of 60, half of all Americans have a hearing loss. Once we get to the age of 70, over age of 70, so it's 2/3 of Americans have hearing loss. Once we get to the above 70 group, and this is relatively new data that our team added to a nationally representative study in the United States that also breaks down by severity of hearing loss. There's sort of two interesting things that we found. Most nationally representative studies didn't really have much data on old adults. Once we get into our 80s, they sort of stop there. So we would just do 80 plus. Once we get to 85, basically every American has hearing loss. It's very, very rare to have quote unquote normal hearing. And these are estimates that would very much make it so that, it's possible that literally everyone has hearing loss, but we give two ends to the estimate. But also what's fascinating is that by the age of 85, it's not just that so many people have hearing loss, it's that we switch from the majority, or the plurality really in this case, being moderate or severe hearing loss. And there are some pretty stark differences there in the way that works for someone. Mild hearing loss is something that you might be able to overcome in a relatively quiet situation, right? It might not actively interfere that much, but if you add some distracting sounds or you take away sort of visual information, it becomes harder. But moderate and severe hearing loss are, even in quiet situations, in best listening situations, people can struggle. And so this is sort of a reframing to what we really knew about hearing loss. At the same time, from a public health perspective, very few people have hearing aids who have hearing loss. This is looking at adults 50 years and older in the United States. Again, it's nationally representative data. It uses some earlier 1999 through 2006 data, but we continue to see the same findings no matter which year we really look at it. And among adults with hearing loss, less than 20% own and use a hearing aid. The actual number in this study was 16.4% of adults with hearing loss owned and used hearing aids. These numbers are a little bit different than if you look at sales data, where it's much closer to like 30% of adults with hearing loss seem to have hearing aids. But this study uses a very specific question about using the hearing aids. And so there is also a discrepancy between people who buy hearing aids and then either cease using them or don't have the support and just stop. So we have multiple issues in this country. One, there's low access in general. And then two, people who do access aren't always supported the whole way through, perhaps. And the story gets pretty deep. It looks like the formatting went off on this slide a little bit, but totally fine. I will walk through it. This is data my team looked at from 2011 to 2018. And what we see is that in the United States, if you look at that sort of gray circle in the middle, we see a 23% increase in hearing aid ownership of adults 70 years and older. That's a big number, and it sounds really important. But the story, when broken down by different income levels, becomes a little bit more disturbing. When we look at people who are older, adults 70 years and older, living at an age-adjusted federal poverty ratio, meaning that for that age group even, they are below federal poverty level, we see a 13% decrease in hearing aid ownership during this 8-year period. For those who are at 200% or more above that federal poverty level, we see a 30% increase. And so it's largely driven by wealthier Americans adopting more hearing aids. But low-income Americans seem to struggle more. And as a public health person, I'm actually very terrified by these numbers, because what happens from 2011 to 2018 is the largest Medicaid low-income federal health insurance program expansion in our country's history. This is the Affordable Care Act, the Obamacare, colloquially named. It's also when we see something like only 10 to almost 30 states covering some form of Medicaid hearing services. And so in theory, we should see a huge expansion in this group, but we don't see anything really. In fact, we see a decrease. So even if there are barriers to entry that are cost related, perhaps, there's more to it than that, right? So even when we have insurance, something is going on. So hearing care can be non-affordable. It can also be poorly accessible sometimes. And we truly don't have enough audiologists and hearing instrument specialists in this country. So when we think about aging and what's going on with older adults and why hearing aid use is so low beyond the barriers to the healthcare system, I think at a fundamental level, this is also just a research issue. If we took a 12-year-old and we had this hearing loss, and below the yellow is hearing loss, we would say we've got to do something about this, right? We've studied it. We know there's education outcomes, speech and language outcomes. We also know sort of how to address it. We have newborn hearing screening programs, which actually the first state to have a newborn hearing screening program, and the leaders in this was Hawaii in 1990. We also have coverage for young children, so under the age of 18, up to age 26 often, state mandates for coverage. We've really sort of put some effort into this, and we screen in the school systems. But if the same John Smith was 72, we would mostly just say, well, everybody your age has hearing loss, and you can do something about it if you want, right? Maybe up until recently, that really was sort of the line. Is it bothering you or not? This means that at a fundamental level, we just haven't answered a lot of the basic questions around the consequences of age-related hearing loss or hearing loss among older adults. We haven't thought about as much the impact about treating hearing loss or demonstrating that impact, and then effectively addressing hearing loss for older adults in the community. So when it comes to hearing loss and healthy aging, a basic way to think of this and how hearing loss really relates to these is, we don't like to maybe think of it, but you are just your brain, right? The outside person you see in the mirror, these are all things controlled by the brain. The brain's the operating system. The rest is sort of this autonomic robot, if you will. And the only way you interact with the world is your senses, actually. Without sensory input, our brain can't really help us be social. It can't respond as much and process the language in the world around us. So it seems to be a fundamental thing that sensory access is the most important area in some sense of keeping your brain healthy. But the truth is, we've rarely really studied sensory loss among older adults. I mean, I shouldn't say rarely. Of course, there are studies, but on a relative scale, it's not something we've thought as much about in some ways, right? We've thought way more about, blood pressure, cardiovascular disease, and how it affects the brain. But sensory loss is how the brain interacts with the world. And so our team, over a decade ago now at Johns Hopkins, and now myself, I'm at NYU, we started thinking about how hearing loss fits in to healthy aging. And I think the one that gets the most attention the one that gets the most attention is cognitive vitality and avoiding dementia. Um, and we want to think about how we get from that level of, hearing loss or sensory impairment to cognitive decline or dementia. If they were just all caused by age or vascular disease or cardiovascular diseases, then there's really no story, right? It's something else is just causing both of them, and they're proxies of each other, if you will. But where it becomes more interesting is if there are these mechanistic pathways, as we might call it, that link hearing to cognitive decline. So I described that idea of cognitive load. Cognitive load is a concept from Danny Kahneman, a Nobel-winning psychologist, Nobel Prize-winning psychologist, who thought about your brain. We tend to say, hey, you're only using 10% of your brain, or you only use 12% of your brain. But the truth is, you use 100% of the brain that's available to you, right? Anything that can process information is processing information. Which means that if we get that bad cell phone signal and we're trying to process that auditory input that's sort of garbled and broken, that comes at the expense of something else. And we sort of believe it may be working memory, but we don't have final sort of models to prove that. But we do have fMRI, so imaging models that are looking at the brain while listening to sound, that actually shows that adults with hearing loss light up, their brain activates in different areas than those without hearing loss, specifically the prefrontal cortex. And what we think that means is that the brain is going into overdrive to process that broken signal in adults with hearing loss, which could lead to that idea of fatigue, but also maybe comes at the expense of long-term memory input of the signal, right? It's harder to put it into your memory if you're working on overdrive to process it. The other area that we think links hearing loss to cognitive decline is sort of this kind of multi-hit theory where hearing loss is its own hit on the brain overall. The auditory system, the auditory pathway in your brain really does cross many different areas, including the hippocampal region, the amygdala. It's interaxial and crosses to each side of the brain. And the idea of sensory stimulation, something that you don't turn off, right? You are rarely ever in a true no hearing environment, right? You're always hearing something. Even when you are asleep, a sound can wake you up. Your auditory system is active. Without that input, though, we think that there's cause for atrophy on the brain and beyond even the temporal lobe. And MRI imaging studies do show that adults with hearing loss have overall white matter atrophy, gray matter atrophy in the whole brain, and then more pronounced atrophy and changes in the temporal lobe region, which the temporal lobe region is where you process language and sound. The other area that we think links these, and I actually think this is the most fundamental area, is social isolation. Hearing, by causing barriers to communication, hearing loss causing those barriers, we believe is associated with social isolation and loneliness. Social isolation is an incredibly important area of aging, and it's often somewhat overlooked. But in 2023, the Surgeon General actually released a report, calling this an epidemic among older adults in America, and it does account for vast unnecessary medical expenditures. It's related to increased mortality, increased morbidity. It's related to dementia. I think what's really fascinating is that we saw work from a researcher named John Cacioppo, who unfortunately passed away several years ago. And he actually showed that being socially isolated, not engaging with people, was literally related to changes in our immune system and our inflammatory systems beyond any other explanation, right? So it wasn't just that you were socially isolated and so you were physically inactive. It was just being socially isolated changed the physiologic makeup of your body, kind of underlying this point that we really are social creatures, and there is this sort of aspect to humanity that you become different. Of course, there are anomalies. There are always anomalies. There are always going to be extremes. There are people who don't, will not respond that way. But on average, his work showed physiologic changes due to social isolation, including dementia. And so what do we see then in the research, right? If we think we have a plausible pathway here, what do we see on hearing loss and cognitive decline? This is work from the Health ABC study. It's a study of 2,000 older adults, 70 years and older, in Pittsburgh and Memphis. They were followed for 6 years. And when you're looking at this, you're looking at a cognitive test score over time at different study time period points over, 6-year point. And those with hearing loss, it's the open circle, and those without hearing loss, it's the closed circle, the full dot. And you're seeing that over time, like even on baseline, there was a difference, right, on their base measures, but over time, there's faster decline in those with hearing loss. When we look at this test called the 3MS, it's a version of a mini mental exam. And it's an exam where we're asking cognitive questions to people orally. So there's an auditory aspect to the exam. We see a 41% faster rate of cognitive decline among older adults with hearing loss. When we look in the same population using a different cognitive test that doesn't require talking, it doesn't require any oral input or auditory input, we actually still see a faster rate of cognitive decline, but it's slightly less. This is kind of a nuanced topic, but I present it to every audience, lay audiences, the public, professionals, because I think we forget that sometimes the very tests that we use to test cognitive function have auditory aspects. And so it's very possible to see the association in their work on hearing loss and dementia and say, well, maybe they just couldn't access the test. But this study is kind of good evidence that even when we take that out of the equation, we still see a faster rate of cognitive decline. This is data from the Baltimore longitudinal study on aging. And what you're seeing in the graphical image is called a Kaplan-Meier. It's a classical way of looking at disease incidence in a population. Every time the line goes down, somebody develops dementia. And so in the top left corner, nobody had dementia, 639 adults. Over at least 10 years, some of them as long as 16 years, we saw a risk of dementia where those with mild hearing loss had 2 times the odds of developing dementia, 2 times the risk. Those with moderate hearing loss had 3 times the risk, and those with severe had 5 times the risk. I think this study is cited often, and I do think, though, that it is important to note this is even though 640 people sounds like a lot, it's a relatively smaller group compared to some of the 2,000 person, 3,000, 10,000 person studies out there. And these numbers are a little bit big, but they have been corroborated by other studies, but maybe to a slightly lesser extent. So when we look at other studies, we see something closer to moderate hearing loss having 2 times the risk of developing dementia. So the natural question is, if we see public health research that shows that there is this level of sort of, association between hearing loss and dementia, well, can't we just look at hearing aid use in that data? And the truth is, it's not always perfect. We have looked at it. This is a study that my team published several years ago. We show that older adults with hearing loss, so 65 years, or this one's 70 years and older with hearing loss, they do have 61% increased risk of having dementia with moderate or greater hearing loss. And even when you just look at hearing loss as sort of a value, just having any increased hearing loss increases risk. And if you look at those with hearing loss and look at hearing aid use, they do show that those who have hearing aids have lower risk of dementia. But one of the things we have to think about in public health data is that the story isn't always simple as the numbers adding up. What I told you earlier about of those with hearing aids, people who have access to hearing aids, especially in the US, are fundamentally different than those who don't have hearing aids. We have higher income, higher education, probably different help-seeking behaviors, probably different support networks and informal caregivers, and different perceptions of hearing loss. And that means that that same group, those same elements, right, of that group, the same descriptors, they also are protective of dementia and protective of cognitive decline. And no matter what kind of statistical package or whiz you want to throw at this, these groups are so different that you really can't just trust this data. You have to think a little bit further about that. And so what our team sort of, has asked is, I skipped a slide. And so this culminates, all these studies, they culminate in this figure, which I don't expect anyone to have seen, but it has become very popular in the press around hearing loss. This is the idea of the what we call attributable risk fraction model for dementia globally. It is a major commission by the Lancet group. So the Lancet is a major medical journal, and they've commissioned this huge dementia group. They took over 5,000 studies and put them into a meta-analysis model. So they took all the studies, put them into a model, and then what they did was they said, okay, if we take all these risk factors for dementia, how much dementia is attributable to each factor, right? And the interpretation of this is nuanced, but I like to walk audiences through it. When you look at this model and you look how there's sort of curves over time, the group tells us that 40% of dementia is modifiable. It's due to a risk factor in life, something that you experience. 60% is unknown or likely genetic, right? The difference between Alzheimer's and like the broad term dementia, Alzheimer's is a genetic condition we can test for and we find markers for. Whereas just general dementia, it could be vascular, it could be other things. There's less of a genetic component, perhaps. When you see that hearing loss is actually the largest attributable risk factor, so they're saying in this model, hearing loss accounts for 8% of all dementia. The way to interpret that is if we eliminated every single case of hearing loss in the world, 8% of dementia would go away. But that takes a little bit further thought too, because I told you that once we get to 85, every single older adult has hearing loss, almost every single, like 95+%. So hearing loss is incredibly widespread, which means that if it accounts for so much hearing loss, then, or so much dementia, then it maybe at an individual level is not the largest risk factor, right? Smoking would be a good example of something that is more rare among older adults and has dropped off in popularity in countries around the world precipitously in recent years. But it still accounts for 5% of dementia, which probably means at an individual level, those who smoke, they're much higher risk. And so a fundamental issue with public health lectures, public health messaging, we tend to see a study like I showed you before that says 5% or 5 times the risk when you have severe hearing loss. These are averages in the population, and they don't necessarily translate to individuals. This is kind of a good way to remind yourself that, we also see studies that coffee is good for you, it's bad for you, it causes dementia, it prevents dementia. We can be all over the place with estimates, but at an individual level, that 1 cup of coffee that you have a day probably is not the deciding factor, given so many different factors in your life for how you're going to have outcomes. So our team, when we think about all this observational data and we think about the difference in hearing aid users, we want to know, well, if we took a trial, would we actually see a difference, right? If we gave people hearing aids in a trial design, would it do anything? And so we did the ACHIEVE study. The ACHIEVE study is a large study of 977 older adults. 977 older adults. I see the questions, by the way. If I see something that's super relevant at the moment, I will try to answer, but I'm actually going to hold, I think, till the end and start going through them. 977 adults, 70 to 84 years with untreated hearing loss and normal cognition at baseline. We randomized them to a best practice hearing intervention and a successful aging intervention. The reason that this is not a placebo study or like hearing aids or no hearing aids is because you can't really remove the impact of just seeing a health professional for your hearing loss. Even if it's not that treating hearing aids matter, there is something about just the contact of health professionals that can affect our behaviors, the way we're thinking about things, the way we even psychologically process things, right? Hearing care is very sort of counseling based, right? We talk a lot about your life, and it can turn into a bit of a psychology based paradigm in some sense, and that could have an effect on somebody. So we balanced the trial with an active control group. So they're receiving something that could also help with their cognition just by seeing a professional and talking about health education topics like nutrition, physical activity, or other healthy aging outputs. An interesting concept of this study is that we nested it within a larger epidemiologic trial, meaning that, 238 participants had been followed in an epidemiologic trial since 1987, right? Just observational data. They come in every few years and they do something, but we know a lot about them, right? And they joined that study in their 40s, and then or their 40s and 50s. And then 740 volunteers were new volunteers in their 70s to mid 80s joining a study for the first time. So we do have two groups. As I said, the groups were best practice hearing intervention or this health education control concept. The health education is an established program called the 10 Keys for those who are interested. University of Pittsburgh is the originator of it. And the hearing intervention was very much just based off of absolute best practice principles from the American Academy of Audiology and the American Speech Language Hearing Association. So after 3 years, when we just look at the two groups, in blue, you're looking at the control, the red is the intervention, and this is called the Hearing Handicap Inventory. Lower scores are better. And what we see is right away, over the course of this trial, like within 6 months, people who received hearing intervention were reporting less functional impairment from their hearing than those who were in the control. So we do see that, despite both groups having an active intervention, if we look at the most proximal outcome, the closest outcome to hearing intervention, just this idea of does hearing loss impact your life, we see big, big declines in the intervention group. That's a good sign for us, right? It means that, we're doing our job, we're treating the thing we think we're treating. But then at the end of the 3 years, we actually see no difference in cognitive decline in the full study. It's a null trial. But it became more nuanced than that, right? A null is always disappointing, but it's still informative to know that. But we had a pre-specified analysis. And this is nuanced, and I do kind of want to walk through it, because I think if you were to look at the New York Times article of our study, you would actually only see this outcome that I'm telling you about right now, 48% reduction in cognitive decline. But that 48% reduction in cognitive decline is in that group that had been in a trial, that observational trial, since 1987. So they were fundamentally sort of different people when they joined a trial, right? Like just following them over time, versus those who are joining a trial for the first time in their 70s. And it turns out when we looked at those differences, the ERIC cohort, or the group that had been in a trial for a long time, they were older, they had more cognitive decline at baseline in the study, they had lower education levels, they had more vascular disease, higher rates of diabetes. They were a much more high-risk group for cognitive decline. And I think what that tells us is that there are two sort of ways to interpret this trial. One, hearing aids do prevent cognitive decline. It just happens much more rapidly for older adults who are sort of at risk of cognitive decline, versus the other group who were much more wealthy, much more highly educated, had larger networks. Or two, It's that we need to observe this for a much longer period, because the control group in the more highly educated group, they also just experience no cognitive decline, right? And it's very like plausible that both could be true to some extent. Cognitive decline is hard to follow. And a lot of people have seen our study and said, well, why didn't you follow them for 10 years or 20 years? And we've responded by saying, we now are following them for 6 years, but the National Institutes of Health, right, the major funding mechanism for healthcare research in this country, they fund in 5-year blocks. And 5 years is about a 3-year trial is about as close as you can cut it with 1,000 people in a 5-year block. So, in some ways, blame the research concept, the questions, but in other ways also, it's just the world we live in. But, I do also sort of point out that this was incredibly informative, and we're hitting a point now where we're thinking about a new 1,000-person trial on best practice hearing care in the group that did show some movement, because we think that that's important to really know whether or not what we saw was just a statistical blip or real. The other thing that I find, sort of telling here, and this is a study that shows it really closely, we don't see this often in studies, and we only see it here because we had that really unique group who had just been in an epidemiologic trial for a long time. We actually see what is called the healthy volunteer effect. The healthy volunteer effect is a concept that the people who join clinical trials are often healthier than the rest of the population. And this is particularly true in dementia research. One of the leaders at the National Institute on Aging sort of said to us when we presented the data, he's like, this makes perfect sense. When we look at a de novo volunteer group, people who are newly joining a trial for the first time in their lives in their 70s, of course they're going to be more wealthy and healthier than the rest of the population. In fact, he went further to say, want to know who's never going to get dementia? People who can afford to join clinical trials in their 70s. And I know it's a tongue-in-cheek comment, but it's true. And it's something that has plagued a lot of research on dementia when it comes to trials, because it is hard to get a good representation of the full population just based off of who can and can't join a trial. So overall, no effect in the full population, but that secondary analysis does indicate that a less healthy existing volunteer group sees a 48% reduction in cognitive decline, and it may just be that they are declining, sort of faster because they are less healthy, so we can observe a change. But interpret it with some caution. As I mentioned before, when we see a population level statistic like these trials, like the epidemiologic studies I showed you or talked about, 5 times the risk or 48% reduction in cognitive decline, they are averages across that population in a study. They are not that if you go get hearing aids today, you will see a 50% cognitive decline reduction. Hearing aids do many things. They are very good. They may help with dementia, but we don't know the individual models, right? That takes a very different, what you would call precision medicine approach that we just don't have. And the messaging for hearing aids, it can be a correct interpretation when you sort of read our research and you see this idea that, dementia is related to hearing loss. And then you see audiologists, manufacturers sort of saying, go get hearing aids and you won't get dementia. It's really not a done deal or, finished science. We may be able to show that there's a higher risk, but we don't know for certain that actually treating hearing loss would prevent it. And we certainly don't know in a given individual. And so I do think, when you see all this data, it can be a scary topic, right? So many of us are going to experience hearing loss. It's scary to think that it's linked with dementia, but I would say this is very similar to, many other public health, studies. Again, the coffee study is also, coffee studies are great studies. So many people drink coffee, right? So many. And when we see it's linked to cardiovascular disease or something like that, if that linkage that we see at the population level were actually true at the individual level, then everybody would have the disease, right? It doesn't work that way though. So I just want to always walk back the research and remind the audience, it's not something that we're doing individual level interpretation here. So while the research was going on, we saw major changes in policy around hearing care in this period. We started that trial, by the way, that 3-year trial in 2019. So just before COVID, actually 2018. And the truth is, actually, we actually finished the original data collection. It's always good to point this out. All of the primary 1-year data was finished before COVID, all the interventions, all the baseline data. And then COVID happened. We had some lockdowns in some of the states we work in. Minnesota, Maryland had some lockdowns. Jackson had Mississippi had less of a lockdown. But by the time we got to 3-year data, everything was opened back up again. And so we do have some analyses showing that COVID did not affect the outcomes in the trial, but we also have very clean data from year 1 to year 3, years 1 and 3, so the change. So on the policy side, addressing public health is a priority. And I think even if hearing care did not impact outcomes such as dementia or cognitive decline, older adults still deserve access to affordable, accessible, and appropriate hearing care. We saw that first study I told you about earlier on hearing loss and incident dementia came out in 2011. It was after a really long period of not seeing a ton of research in this space at the public health level. But the truth is, there's actually a paper from 1989 that does start to hint about this concept and published in JAMA. And then it kind of we don't see as much in the more broad literature. But I do think audiologists have always had a bit of a handle on this, to be honest. They just look at it through a more narrow lens often. And then the full trial for Achieve, it was finished in July 2023. And in that interim period, from 2015 to 2017, we had huge changes. At the White House Conference on Aging in the Obama administration in 2015, the President's Council of Advisors on Science and Technology put hearing loss on the docket as a tier 1, top tier priority for aging. Some people speculate that this also coincides with Michelle Obama's father getting a hearing aid. I have no way to corroborate that or not. We just hear it all the time because usually hearing loss is a little bit lower on the scale. But that led to the President's Council of Advisors on Science and Technology putting out a statement saying we need to change hearing care in this country. And one of the things they suggested, which was more spelled out in 2016 in the National Academies of Engineering, Science, and Medicine, Science, Engineering, Medicine, the NASM Academies, they came out and talked about over-the-counter hearing care being a way to change, the access to hearing aids in this country. And the basic concepts of this were sort of breaking up hearing care. And I'll talk more about it in a second. But that became a bill in 2017, introduced in the Senate as a bipartisan bill, truly bipartisan. We don't see that very often anymore. Chuck Grassley and Elizabeth Warren. You rarely see, both sides sort of supporting something. It eventually was put on as a rider onto the Food and Drug Administration Reauthorization Act, which, for those of you who know anything about policy, know that's how a lot of policy happens in big bills with tons and tons of things in them. We no longer seem to vote on small things, but it did pass in 2017 and was signed into law. And we saw sort of these concepts from Elizabeth Warren and Chuck Grassley thinking about why we should do this. And I think you sort of break it down into a few concepts and things happen. One, this is actually self-disclosure. This is my research. It was part of the federal testimony before Congress in supporting the bill. We had massive changes in technology, in hearing care technology, that we actually had these devices called personal sound amplification products at the time. And some of them were pretty affordable, $350, $250, $200, $300. Some were really, really cheap, like $30. And a lot of those were too good to be true concepts. But we actually compared them against a $2,000 hearing aid, traditional hearing aid, and we saw that they basically could get adults with hearing loss the same speech and noise benefit when they were all under the same conditions. And we had people come in and use the different devices in a random order and repeat back words and noise to us. And we saw fascinating results, right? They were basically the same, despite these huge cost differences. And I think the technology had just progressed to a point where you could do some interesting things with digital devices, and especially with smartphone linkages, because the processing power from a smartphone is strong. It's like carrying a powerful laptop in your pocket. The strategy for over-the-counter hearing care was really a market-shaping one. And the idea was, in hearing care, especially in the United States, but globally this is true mostly, we had an idea that you had to buy a hearing aid through a licensed individual. It could be an audiologist. It could also be a hearing instrument specialist. Those are sort of different practices, but they both were licensed to sell a hearing aid. There are some areas where nurses will get the license, especially in rural communities. You can get the license it depends what state you're in, but some states it's just a high school diploma and passing a test. Some states there's more to it. Some actually have to do an in-person test. It's different across the country, but you had to buy the devices through a licensed individual, which meant that we were limiting the sort of pathway. It also meant that with only 5 companies making hearing aids and really owning a lot of the market, right? And living in a world where some of those companies also own practices, right? They own the audiology clinics, they own the hearing clinics. We had a very vertically integrated world, which made it hard for a new manufacturer to break in. So it meant that market competition might be low. This meant that if Bose, which was a major proponent of the Over-the-Counter Hearing Aid Act, wanted to sell their hearing aid, they needed a new way into the market. And so Elizabeth Warren and Chuck Grassley proposed that this would break up the market and allow for new market entries. We could see companies like Sony or others. It also meant that we would start to separate the provider from the devices. And I think this is kind of a concept where perhaps a hearing aid, like an audiologist, was seen as like a car salesman in some ways. They sold you a device, right? But the reality is they're much more like a mechanic and a specialist than somebody interested in selling. It connected end users to the manufacturers. And there was this belief that if we got new consumer technology brands into hearing care, we would see massive changes in the marketing around hearing care. So the idea was we would go from having one gold standard hearing care with an audiologist, for example, to having different models, consumer-directed models where you could buy something and use your smartphone to fit it and make it work for you and customize it, hybrid models where you could buy something direct and go to an audiologist still if you wanted. You would have that choice. And then the traditional sort of prescription gold standard model where you were working closely with the audiologist across the path. Many different ways to think about it, but in a world where less than 20% of older adults, or less than 20% of adults who have hearing loss own and use hearing aids, there's certainly room to change the market. And so this passed, it finally came, or sorry, even before the OTC part came out, we had a vote for the Build Back Better bill, which was the first time that Congress got so close to expanding Medicare to include hearing aids. Unfortunately, this did fail by a single vote. That was, the Joe Manchin holdout from West Virginia. But when Medicare was created in 1965, hearing aids were a statutory exclusion, which means it's going to take an act of Congress to change that. And so we still remain without any hearing aid coverage in Medicare. Medicare Advantage plans sometimes have it, but it is something that you have no Medicare coverage for. There is no insurance, so it still is largely out of pocket. There were a lot of opportunities with that idea, though, of Medicare coverage, because it could also help us move away from a model where the hearing care we think about is the audiologist selling a hearing aid, right? To sort of an unbundled model where we just let the audiologist sort of practice their services and let something like the insurance side really cover the devices and think a little bit about that more broadly. So it could have had a really strong path to changing the landscape, but unfortunately it didn't pass. The truth is, though, the language from that bill just keeps getting introduced over and over again. And so now we're thinking about Medicare coverage in the OTC era. Would we have covered devices separate? There were a lot of complex processes. And I think the bill did a good job of sort of laying out that, this was complicated, but the first process, and the reason I sort of even talk to audience about it, is we need Congress to actually change this because it is a statutory exclusion, right? We do want to see something change. but CMS might be able to think more deeply about it at the administrative level if we can just get the statutory exclusion removed. After that, sort of I don't call it a fiasco. I'll call it a defeat. In full disclosure, I spent my entire summer of 2021 working with the Senate on the language for the bill in Build Back Better for the hearing care part. So it felt like a defeat on my end. But in 2022, we did see the FDA finally make the final regulations for those over-the-counter hearing aids, and they are now available to you. But a key distinction that occurred was that they made over-the-counter hearing aids something called 510K exempt. 510K exempt means that you're not really in a world where the FDA is approving hearing aids. Instead, the FDA just, lets people register with them saying, do you meet the basic criteria, right? That's a very different world. So that means that over-the-counter hearing aids don't have to show any, clinical trial evidence that they do what they say they'll do, unless they use the language self-fitting. But admittedly, at this time, we have very few companies really entering the self-fitting OTC hearing aid world. But that does mean it's a much higher level of rigor if you see that term in the real world and you're looking for over-the-counter hearing aids. By making it exempt, the FDA allowed for the market to be flooded. So instead of seeing just a few really strong companies get in this space, we saw thousands of companies start selling hearing aids based all over the world. And so if you were to, check this on Amazon, you would see a lot of options. And it's really hard for a consumer to sort of navigate those options. So you can rely on that self-fitting designation, but I think more broadly, there is some call to be made to the FDA to think about consumer protection in this sense, because what we had before was a traditional model which had access and affordability issues, but the consumer was protected by the audiologist or by the person selling the hearing aid. There were regulations around warranties. There were regulations about return periods. Somebody was sort of curating that selection for you. No longer, though, on the direct-to-consumer side, do we actually have that same protection, right? So now it's a much more sort of murky market, and it's very easy to buy a device that might not work for you, for example. So while I think that we've seen a lot of progress, I think there's a lot of work on the policy side that needs to be done. And I think it has direct implications for how you and others might navigate the market at this time, using that self-fitting term, for example, as a way to sort of look for a higher quality, I won't even say higher quality device, but a device backed by some science. So what can you do today as we wrap up? I do think in the OTC side, we still, there are both OTC and professional options. We want to encourage people to get a hearing test. When you think about the public health side of hearing screening, you're sort of tested throughout elementary school, right? People tend to remember those people coming in, you'd hear a beep and you'd raise your hand, and then never again until somebody tests you when you're older, right? We have this really long period. And so one public health initiative is just thinking about building awareness by just getting more baseline testing. It's so hard to notice when you're losing your hearing that we often go a long time without doing anything about it. So early testing, there's also now, as a non-professional option, you can test your hearing with an Apple product using the AirPods, and it's very close. And there's studies showing that it's basically the same as a professional test. And that's really, really like sort of a game changer in some ways, that we're starting to see accessible technology in the field that can do a high quality test. There are the hearing aid options. You have the professional fits or the over-the-counters. We do have some very strong companies getting involved now, and it's more recently Apple, designated their AirPods as hearing aids. I do always say look for that self-fitting label. Sony is in the space now, so there are some really big, more trustworthy companies that are backed by sort of a history. You can do hybrid models. There are also other products. And so I put cochlear implants on here as an example of, we kind of think of cochlear implants as a capital D, deaf community concept, or really not even deaf community, but profound hearing loss community concept, right? Because you're literally doing a surgery, you are changing the ear, you're using an electronic device in your ear to sort of stimulate the brain, or stimulate the organ of hearing, the cochlea, to send signals to the brain. But more recently, we've seen more use in older adults and more successes. And we've even seen models of cochlear implants that don't require you to have that profound hearing loss. So we're seeing some changing aspects there, and how that's effective in this older adult populations. We also see a lot of people using, or we even recommend using amplifiers that are handheld. But I do often point out, and this is kind of true of the OTC market too, proceed with caution with some of these. They can be very useful in situations where they're sort of static and sitting in a room and talking to somebody, but they sometimes amplify all sound. And I do want to go back to that thing in the beginning. We don't need all sound amplified, right? So if this device amplified everything a little bit, you might see something like this line, right? A little bit of gain, a little bit of amplification everywhere. But what you need is more like this, more amplification at the high frequencies, right? Where the hearing loss is. And so there is this sort of aspect of balance between a device that sort of can, be used as easy as low cost, does a lot, versus something that really customizes for your hearing needs, your specific or someone's specific needs. I also always push for this kind of concept where hearing loss does kind of start, and addressing hearing loss starts with just thinking about the broad communication considerations, right? And what's available in our everyday lives. There are technology considerations like the handheld amplifier I just showed you, caption telephones that have captioning on the phone at a big screen, video conferencing that can be used in rooms, speech to text with the Android and Apple phone systems that are very accurate now. They've gotten really good. Smartphones can amplify. I told you Apple actually has their AirPods as a hearing aid. So there are some things that are sort of integrated into our everyday lives already that could help. But thinking about the environment, so when you're communicating with someone with hearing loss or when you're advocating for yourself, getting rid of background noise can be important. Improving the lighting, because we use visual cues, and whether we believe it or not, most of us do lip read a little bit and rely on those cues for communication. You can also, in certain situations, have pre-prepared placards or whiteboards or tablets to help with communication. It sounds kind of hokey, but it's actually very effective in healthcare settings. And there's a few small studies actually showing that people appreciated it as well as it improved patient-provider communication. And the last part is we sometimes just forget that we need to change our communication strategies. And I'm guilty of this. We're all guilty of it. Ensuring someone has your attention is actually where you start a conversation, right? So tap on the shoulder and getting them ready for the conversation and ready to be attentive. Face-to-face communication in healthcare settings, a big pet peeve of mine, and this is not the physician's fault. They live in a world, physicians, where they're constantly on a computer taking notes, right? They're seeing so many people a day. They have to do them together. But face-to-face is incredibly important for someone with hearing loss because they use those visual cues. Visualization of the mouth. This is also, something that during the COVID era we struggled with, and we had to think of those clear masks when we could. Slow and low. What this is with hearing loss, most people have high frequency hearing loss. And so lowering the register of your voice actually helps, right? Kids who talk really, really fast and really, really squeaky and high-pitched voices are the hardest to hear. So going a little bit lower in your volume, if you will, or in your frequency range or pitch is super helpful if you can. Shouting makes it worse. When you shout, you tend to actually exacerbate the sound. You make it more difficult for someone to understand. And so the natural inclination of most people is to shout at somebody. But in reality, it's more about maintaining your same, tempo of conversation and going lower. Giving context to the conversation. This is, if I say, that concept of you should go to the pharmacy before you get to your house. Again, if I start talking about your medication more generally, you might be able to put that sentence together more than if there's no context and no background. And then rephrase rather than repeat. If someone didn't hear you with hearing loss, right, the first time, if you say, hey, what'd you have for breakfast? And they say, huh, and you just keep saying, what did you have for breakfast? And shouting at them, it's likely that sentence is just difficult to understand from for their hearing loss. So changing the sentence up, asking about, cereal, pancakes, oatmeal, whatever, talking to that person about, eating in the morning. These can change how they understand it. And so I think our habits are to sort of shout and repeat the same thing louder, but the reality is changing these communication tips can go a long way, particularly the last two. And when I think of hearing loss and caregiving, I really think that, that communication side is the foundation for improving, success with hearing aids. I also think that, more broadly, this is a topic we're going to see more and more. We're living in an aging society more in general, right? Everybody is living longer. And if you look at recent data from the National Study on Caregiving, the average age of people who report being caregivers is rapidly increasing. We are very likely hitting a range where a large proportion of those who identify as caregivers also have hearing loss. And I think that this is something that, in the context of this scenario might get lost a little bit. We sort of think of like, the care recipient being older, so they're the one with like the bad hearing loss or something. But the reality is we may need to go back and remember, both sides could have some hearing loss, and that could make for even more difficult conversations. And so, we don't want to wait for this to be something that is only sort of part of oldest old, but it's a part of like our life course. Knowing the symptoms can be incredibly important. So as people, age, it's less that they're asking for people to repeat as often and more that they sort of think everyone around them is mumbling. Sometimes the repeating thing happens, but oftentimes because it's a clarity issue and not a volume issue, like we covered in the beginning, that actually means most people are like, well, you're mumbling, right? And it's so easy to make that mistake. And, when you think about just the physiology of hearing loss, it's easy to understand why that mistake is made. But earlier referrals, if you see somebody doing that and struggling, can help with this. And it can, helping to understand that hearing and cognition are linked, the way you process speech, the way you process sound, could, also lead to earlier, intervention and maybe, if true, preventing some cognitive decline over time. And then, like I said, the communication barriers. And so with that, what I'll do is jump into some of the questions here. Thank you for your attention, and happy to take more questions, please, if anybody wants to put them in the chat. Jody, would you prefer?
Yes, go ahead. I thank you so much. Oh my gosh. I'm going to feed you the questions and read them out loud. So if anyone's on the phone, they can hear the question.
That's great.
Thank you so very much for this thorough, informative presentation. It's just amazing how much work you've done. Thank you for the work that you've done and are doing about this. Really, really appreciate it. Okay, we'll go to the questions. Should seniors do a yearly check on hearing ability?
It's a great question. And so the idea of a yearly check, I think what's more important is that as we get into our 50s and 60s, is just getting a baseline check. Hearing changes so insidiously and slow that yearly might be overkill to some extent, until we're well into our 80s or 90s. But I actually think just starting earlier is even more important. And then, yes, regular checks would be important so that we're becoming more intimate with, an understanding of our personal hearing.
Thank you. I am a candidate for impending hearing loss simply because as an 80-year-old, I'm sensitive to loud or high-pitched noises. This is just a comment here.
Yeah. Yeah, if you want to say a little bit more, I might be able to, if there's a specific question, I'm happy to take it. But there is a sensitivity concept that comes in, and this might be counterintuitive, but I will address it. Something that happens with hearing loss is that, you know what, I'll stop sharing so you can see me a little bit more on the screen, if that's okay. Please in the chat, someone tell me if I shouldn't do that. But I think that with hearing loss, your lower threshold of where you detect sound that changes, right? You're having more trouble detecting soft sounds, but loud sounds are still there, and you're still hearing them at the same level. And so sometimes we become sensitive to loud sounds with hearing loss because the range of going from soft to loud has shrunk for that person. And so you can imagine it's like, you know, if you have hearing loss, or let's say you have, normal hearing, you hear during a thunderstorm, you hear the wind, you hear the rain, and you hear the thunder. But then as you develop hearing loss, you no longer hear that wind. And even more hearing loss, you no longer hear the pitter patter of the rain. And just out of nowhere, you hear thunder. That can be really disturbing, and it does change people's sensitivity. So it's actually a great comment in some ways because it helps sort of understand what hearing loss is like. It's not just that everything is quieter, it's just access to some of those soft sounds.
Thank you for that. While we're on this topic, Dr. Reed, if someone is caring for someone with dementia, this is my own question, and there are these interfering sounds like a TV on, radio on, ambient sound in a crowded place. I know this is an issue, and obviously, if someone has dementia and hearing loss, it's going to make it practically impossible for them, right? So I guess your advice to caregivers about loud TVs if they're trying to communicate with somebody, or ambient noise.
Yeah, removing background noise is such a key part of communication. And when you have hearing loss, you know, you're missing, you're struggling to hear some of those soft parts, and it's a clarity issue, not a volume issue. So removing competing sound becomes even more vital. So if you have the opportunity to turn off a TV or remove, people from noise, or even like, you know, uh, I live in New York. I lived in Baltimore. They're busy cities. Sometimes just closing curtains in rooms can go a long way to preventing some of that street noise that was interfering with communication. So lots of options. Anything you can do to reduce interference, though, is good.
Thank you. Do deaf children have shorter lives because over their lifetime, their brain's process is less? I'm not quite understanding that question.
I should, one, this might not be the exact answer to the question, but I want to point out that the research we talked about today is in older adults with sort of that age-related hearing loss. So this represents sort of the change in their hearing over the life course. Um, we don't have studies at a population level, like really large studies, looking at people who were born with hearing loss, congenital hearing losses, or who identify as capital D deaf, and cognition. And it may be different too, because, in some imaging studies and sort of if you think about the communication, especially somebody who was born with hearing loss, congenital hearing loss, and, uses ASL, American Sign Language, or any sign language, their brain has rewired. It's seen some neuroplasticity that they may not have sort of the same link between this age-related hearing loss that's more common through the population and happens to most of us, uh, and sort of the mechanisms for dementia or cognitive decline than somebody who was born deaf. They really are sort of different theoretical models, and it's worth sort of mentioning that it's not that somebody who's born deaf would have dementia or something like that.
Thank you. Any tips on encouraging elderly to actually use their hearing aids, or any hacks to optimize their clarity of sound, e.g. settings on electronic devices, earphones, or for televisions, etc.?
Yeah, for encouragement, I mean, it really, the encouragement can be a lot of things because some people don't adapt well to hearing aids. And sometimes that's actually, on the provider's fault of not really setting expectations. I don't have as much time in the clinic as I'd like, and I rarely even do it anymore. Really, I've become much more of a researcher. But when I was clinical, I talked about, hearing care kind of like the little engine that could trying to get over a hill. I mean, it really is hard. If you can imagine that you have had hearing loss and you've been living a certain way for quite a long time because it's so slow and it happens over a long period and most of us don't notice for a while. you've really adapted to that world in some ways, right? You're missing some sounds, and those parts of your brain haven't been stimulated as frequently anymore. Um, I would say this isn't like it's not that far of an analogy to say this is kind of like when you move your arm after it's been in a stationary position for a while, and it falls asleep. It's almost like painful, right? Like you really feel it. You're activating an area that hasn't been stimulated a lot. It's almost painful at first to reactivate some areas. It's also hard, right? You've forgotten some sounds. Like something that people report to us in the clinic all the time is they forgot how loud toilets were because it's a really high frequency sound, or running water. And, you know, that's disturbing. So one of the things that, we encourage and why we frame it as this is not a cure, this is not something that actually makes sound immediately helpful, is that this is retraining your brain and it takes work. It is like going to the gym. And for the first several months, if not years, you will continue to see improvement if you really put the time in to force yourself into these bad listening situations and force yourself to get used to the hearing aids. The other side of encouragement is, what's worse, missing conversation and potentially affecting your social life and social communication and asking people to repeat themselves all the time, or, just wearing the hearing aids. It really depends what the problem is. And then tips and tricks for technology, multi-part question. I think the biggest tip that I could give anybody is most hearing loss is high frequency. That is the treble. But if you give somebody, and you can go do this experiment yourself, if you give somebody the option to change treble and bass, they will start changing the bass and think that it makes a bigger difference. And that's because bass, low frequency, is energy and it's volume, and we notice it. Treble is a clarity thing, and we tend to barely notice it. But that's actually what you need. And what oftentimes somebody will do when they're messing around with their own electronics to address hearing loss is change that bass, because they were like, well, that's louder. That must be good. But it's not loudness that you need as much as clarity.
So on the question of the electronic devices or earphones for televisions, there's a very good Sennheiser, earphones for people, and you can adjust all of that, right?
Yeah, you have a chance of that with the treble side, yeah.
Mm-hmm. Okay. Has there been any correlation between hearing loss and vaccines such as COVID? How about exposure to smoke and illegal substances like meth?
There's no evidence for hearing loss in COVID vaccines. To give you an idea of where I'm speaking from, I sat on the National Academies of Science, Engineering, and Medicine COVID Vaccine Adverse Events Committee for 3 years. This is the scientific body that is appointed to look at adverse events related to vaccines, and we specifically did the COVID vaccine. We're called by CDC and HRSA, and we did find, there are evidence, right? It was a very, very influential report, and it does show that, there are some things that could be real, but we saw no evidence for hearing loss from COVID vaccines. There's just no data to support it whatsoever, whether it's on an animal model or human level data. But exposure to smoke, yes. Smoking seems to have a link to hearing loss. It's not as clear, though. There seems to be a direct link, just smoking, and some drug use too, but more importantly, it seems that smoking actually changes your vulnerability to other causes of hearing loss. And so ototoxic medications, there are some medications that are life-saving, right? Aminoglycosides is sort of like, they're not antibiotics, but you might compare them to like antibiotics, but they're much stronger. They can cause hearing loss. And it turns out that, when you're on something like that, or some chemotherapy agents, smoking increases your vulnerability. It also seems to increase your vulnerability to extremely loud noise and your system's ability to recover. And we know that noise really is the primary driver of hearing loss, like over the course of your lifetime. Your age-related hearing loss is kind of an amalgamation. It's a final sort of equation of all these different things that have happened over your life. But we listen to sound very loudly, right? It's not just at work, even factories, but railroads, cities, the way we listen to music, concerts, it's just loud all the time. And there does seem to be a link that smoking prevents sort of the recovery and it causes more damage from noise. So link to it. Illegal substance research is a little less advanced on the hearing side. So there's a few people that have reported links, but I don't know of any sort of definitive evidence there.
How has less education how does it impact dementia?
How does less? Oh,
I think as a risk factor.
yeah. So lower education is linked with poorer health behaviors and poorer access to healthcare. And so just like with hearing loss, it's not a direct risk factor. It is a risk factor that, you have to think of the pathways in someone's life. And so just being, lower educated on a global scale seems to cause many downstream effects that do lead to dementia per the reason for like public health researchers.
This is the same theme as in a previous question. How can we encourage people to use and adjust to hearing aids?
Yeah, to go more on that, I do think it's about the framing of, setting expectations. These aren't going to make everything good right away. They might make some things might never improve, right? They really are not cures, they're aids. We're not actually fundamentally changing the hearing system. And that goes a long way, just starting that. But then giving people tasks. And what I like to literally have patients do is get two radios. So, or start with a TV and a radio, or two TVs or two computers, doesn't matter to me. Put one on a news show, talk, and one on, maybe let's start with something like music. And start with the news program and focus on it with, you're wearing your hearing aids, and play some background noise. And then start to change that scenario. Turn away from the news program, turn up the background noise, turn two news programs on at once. These sound like nightmares, but the truth is, it's a brain game, if you will, to help adjust to the hearing aids, right? By forcing yourself into worse situations, you are doing the equivalent of a muscle, workout, right? This is like physical therapy for your brain. You're forcing yourself to get used to it. You're forcing yourself to learn those cues. And, there's something psychological that changes about us when we realize that, this isn't a pharmacologic pill. It's not something you just take and the whole world changes. It really is working out in some ways and getting used to it. And it takes some effort. I think that goes a long way in helping change people's behaviors.
Dr. Reed, I just want to double check on your time. It's 11:22 or your time, 5:22. Do you have a little time to answer all these questions? Because we have 11 to go, and we could always attempt for you to answer them later, and then I can send to the person.
We'll see if we can get through them.
Okay,
a little after 5:30, but
just let us know when you need to leave. Know of someone who suddenly lost hearing that led to vestibular disequilibrium for constant exposure to cigarette smoke and exposure to cooking and smoking of meth. Quite perplexing, as the exposure to substance abuse is detrimental to folks who may be residing in areas that are infiltrated by drug addicts. Moving may not always be an option since housing market is already a crisis. Plus, there is no guarantee that other areas may be smoke or drug free.
Much more of a comment, but yes, tough situations. Sudden hearing loss secondary to cigarette smoke is really rare. Most sudden hearing loss, if you looked at the literature, is usually due to an infection of the eighth nerve. There are a few different other concepts there too that present, but rare for it to be sudden in that case. And vestibular disequilibrium, the idea of balance, that does happen sometimes. So really tough situation, and you're absolutely right. People can't always get away from some of the exposures.
Is it a general hearing aid to cover all different symptoms, or are the hearing aids made for specific hearing problems? I've seen ads for over-the-counter sales of hearing aids. Seems questionable.
So the over-the-counter hearing aids, if you just see the term over-the-counter hearing aid and nothing else, that means they've registered with the FDA and they say they'll do the bare minimum, but it doesn't mean that they've proven anything. If you see the term self-fitting over-the-counter hearing aid, that does mean that, they've done a trial to show that you can use like a smartphone, for example, to really fit this hearing aid for yourself and do it relatively equivalent to an audiologist with that technology setup. As far as different hearing aids for different symptoms, the traditional prescription hearing aids, they pretty much cover the gamut, the ranges of hearing loss. However, if you have really profound hearing loss, there are like ultra power, super power hearing aids. Those will never be over the counter. They get way too loud. They could be dangerous, really. And over the counter hearing aids, broadly, they're designed for mild and moderate hearing loss and not really severe hearing loss. But the technology specs that they gave companies to work within, the goalposts are pretty wide. So some of them could work for people even with perhaps severe level. It's actually self-report. How you self-identify. Is your hearing loss mild? Is it moderate? They're made for mild and moderate hearing loss in that scenario. So in general, 99% of cases, a prescription hearing aid or a self-fitting hearing aid can fit most, hearing loss, most age-related hearing loss. There are some more severe hearing losses that need something like the ultra power or a cochlear implant, or there are other types of hearing loss, like conductive hearing loss, that could be surgically corrected. This means that something is blocking sound from getting to your ear. There are permanent conductive hearing losses where we do something called a bone-anchored hearing aid that actually uses vibration. But while in clinic, these are something we see on a regular basis because it's the clinic. At the population level, we're talking about less than just a few percent of cases. So I think if somebody was in that scenario though of like symptoms of hearing loss that they really need one of those more medical models, most likely they would know and they would end up in that pathway.
Thank you. If one does not use hearing aids when the nerves from the ear to the brain are connected and functioning, do the nerves die and hearing aids do not help at all? My friend in her 90s was told hearing aids would not help her now, that she should have gotten aids in her 70s and 80s when her nerves between the ear and the brain were connected.
Yeah, I think that it's extreme to think that the nerve dies or that nothing can sort of recover. But I think it is true that the longer you wait, the harder it is to adjust. And this gets to that idea of hearing aids are not a cure. They take work. And if you've really waited a long time, like if you don't get off the couch for 30 years, going back to the gym is going to be really tough. And so I think that the idea that they would never work for her is a little bit overstated. Will she have, in this scenario, would she have a harder time adjusting to them? Probably. Has she missed the window to really maximize benefit? Also, maybe, right? The longer you've waited and really avoided it, just like with the gym scenario, waiting 30 years will make it harder to get back in the gym. It also means you've probably missed some window to really maximize your powerlifting or whatever people want to do, right? That does change your avoidance behaviors can change the some of those, but it's not an absolute. So I would discourage people from thinking that you could never get anything back. Some is better than nothing.
Thank you. I'm going to skip another question about trying to convince someone's mother or father to use their hearing aids, because I think you covered that earlier. This seems like very difficult for people. Does getting your ears cleaned regularly help hearing, or do dirty ears significantly affect hearing? I would like to share something here. I took care of my dad with Alzheimer's, took him to an audiologist, and he had a gigantic earwax blob in his ear. And that was the first thing that doctor did, was remove this incredibly large earwax. What do you have to say about that, doctor?
Yeah. It wax rarely truly impacts the ear. So even a little bit of a space sound can get through, but wax can become impacted without ear cleaning. It does happen. Your ears sort of naturally clean themselves throughout our lives, but older adults it gets dry and it does though, it sort of affects oftentimes people report hearing better, and what sometimes they actually mean is it's just more vibrant, more access to sound. Your ear is a trumpet. I mean, literally, what I mean is it has a resonant frequency. It has this outer side that lets sound funnel in. Our anatomy is fascinating in that our ear actually adds volume naturally to the same frequency range that we speak in, like our speech frequency range. It's like we're designed to work this way. And so, the wax can impact some of those resonant frequencies. It also just feels better. So, I don't want to like missell it that like, oh, you got to get your ears cleaned because that'll help you hear or something, or it doesn't really cause hearing loss necessarily in the sense of permanent hearing loss, but it can be quite relieving and can help on some scale.
Okay, I just purchased 2 hearing aids, Starkey Livio Edge AI 2400 rechargeable. Boy, that's long. Lion H ITC digital from an audiologist. The hearing testing was covered by Medicare, but not the devices themselves. The cost of the devices was $7,486. HMSA paid for $2,240, and I had to pay the rest of the cost. Very expensive, but worth it to me to mitigate and slow down my hearing loss.
It's good. It's good. It's great to hear those kind of stories that it's helping.
Many people with hearing aids don't know how to take care of it, and if they have a problem, should check with their audiologist. We had to take my mom several times if she had problems with her hearing aids. Audiologist had to recalculate her hearing aids because of her hearing changing.
Yep. Yeah, absolutely. So, once you enter into hearing care, your hearing loss actually doesn't stop, right? The physiologic changes, they keep changing. And we are sort of all losing our hearing over time. And so on sort of regular increments, you need to have them sort of readjusted, changed for you. It's also an electronic device. And we sort of stigmatize hearing aids as some sort of hokey-dory, product. But the truth is, they win awards all the time because you're cramming the processing power of a laptop computer into something the size of a nickel and then putting it in your ear, which is like dropping that laptop in a swamp. So hearing aids are actually incredible devices, but they are electronic devices that do require upkeep.
Yeah, I'm going to speed through this. My spouse recently underwent a hearing evaluation by an audiologist who confirmed that his hearing is generally good. Despite this, he faces difficulties in noisy environments, particularly in group settings with multiple conversations. He also finds it challenging to hear clearly over the phone, and during one-on-one discussions, he often has to turn his head to better utilize his left ear. We have been seeking guidance from his primary care physician with no real solution thus far. I'm concerned for him, especially considering his job in an auto shop, which exposes him to loud sounds. I would appreciate any advice on ideas or ways to address these hearing challenges.
I mean, there's a lot to unpack here. A lot of the loud sound would cause something that the audiologist might have picked up. I will say though that, it's possible that the audiologist didn't pick up like, advanced hearing loss, for example, or something more severe. But even mild hearing losses, no two hearing losses affect people the same way. And so a mild loss can affect someone, quite dramatically. I also think, though, that, hearing and the act of hearing, it is this idea of access to sound, but that's not listening necessarily, right? When we think about processing speech, right, that is a cognitive task as well. And so hearing is both access, encoding, and then central decoding with the brain. It's a bigger pathway. And what we focus on as audiologists and ENTs and other folks, we're often just focusing on the ear part. Does the encoding part work? But communication can be hampered by other sort of brain function aspects. Auditory processing disorder is the concept that you have quote unquote normal hearing, access to sound, but your brain isn't processing it. It usually is something that's we see as a phenomenon in children, but I think there actually is a more robust literature more recently with adults. So, you may want to ask an audiologist about that. It's impossible to give sort of, any advice other than just sort of beyond, hopefully if you keep trying and asking some questions, you might get directed to the right person.
Are you okay with answering 3 more questions, Dr.
Sure.
Reed?
Yeah.
Okay. Can the loss of hearing be related to balance and increased risk of falls?
Yes, absolutely. We focused on a very specific topic today, but there's also a relatively growing literature on as we lose our hearing, we're more likely to fall, we're more likely to have balance issues. We even have like slower walking speed due to hearing loss. And it really is two things. One, your hearing is in the same part of your body that controls your balance, your vestibular system. That is all one structure. It also is just that your hearing is sort of your spatial awareness. And so as you can imagine, studies show adults with hearing loss are more likely to have traffic accidents and are more likely as pedestrians to struggle in crowded areas. There's injury risk that comes with not having that same level of awareness of surroundings.
Do earphones for TVs, etc., make for hearing loss because they're so loud? I would add in there stuff like earpods and music, but
Yes, they increase the risk. So, um, you know, it's not as bad as it used to be. I will say that, we did get some consumer technology protection where you actually cannot turn phones up as loud as you used to be able to turn them up. Um, for everybody who lived through the 90s, for example, we had like these, radios and stereo systems that could get loud enough to almost cause instant hearing loss. And we just allowed that, right? Around 2000 in the digital era, we started to change some of that. And we've seen even more changes where, phones have limiters, output limiters, and they'll even warn you. But still, uh, you very much are putting yourself at risk by listening to very loud sounds. And there's also a difference between listening to in the ear earbuds and over the ear earbuds, right? Those in the ear ones change the volume of space, the actual amount of space between your eardrum and the sound source. And that small change in volume can actually increase the pressure on the eardrum that could make you more susceptible to noise damage versus an over the ear one that's allowing for the full canal and the system to breathe a little bit. So yeah, I mean, I still wear headphones, I do my morning walk through the city with my headphones on, but I keep it as low as I can. I really do think that it's worrisome how loud we operate in our lives.
okay, one more question.
Yeah.
Can you train your brain to increase vigilance to the high level sounds? What can you do to increase clarity?
Can you train your brain to? I think if I'm interpreting this correctly, and please, if you want to chime in really fast, if I'm not, the concept of hearing loss with those high frequency sounds is not necessarily that, hey, you have access to them and you're just not getting them to your brain. The literal cellular structure that would encode those sounds isn't there. It's breaking. And so you actually just don't have access to it at a certain volume point. You can concentrate really hard, but what we're saying is that it's not about concentration. It's quite literally physiologic access. So the real way to increase clarity is by giving you some sound source back. Or, before we get to that full point of not being able to access it, but in the more difficult regions, adding those things like context, rephrasing, removing the background noise, things like that to make it slightly easier to get by with what you do have. But you can't restore the area that truly you don't have access to.
Thank you. You did understand what she was asking. Doctor, there are a few more questions, but you have the option. You could email me the answers and I could email them
Um,
to the people, or do you want to answer them?
we can get through them real fast.
Well, thank you so much for that. Wow. Back to the COVID vaccine, I've seen studies showing cell mutations. So could that show effects to hearing loss? Um, myself, I had vertigo, and I worried it was the COVID vaccine. And I did some research, Dr. Reed. There's a little bit of research that shows an increase of tinnitus and stuff like that. It doesn't seem to be,
No, so I'll say,
yeah.
the approach we take is for those big reports. I've read every study you can think of. Myself, there's 60 of us, or sorry, there were like 39 of us on this committee, and we use a scientific approach called meta-analysis, where we put all the studies together and we actually start collapsing them and we read them. We put their data in ourselves even, and we pull up the systematic reviews and we look for flaws in the studies as well. So hearing loss particularly had a major flaw in that a lot of the studies were sort of self-report and they were older adults, and there's no evidence to give us a before and after. And one of the bigger things is we just didn't see any animal models, like biologically plausible models, to support a lot of this. A lot of times what actually happens with vaccines and adverse events was something like tinnitus. So tinnitus is a great example. Hearing loss is a good one too. So many of us have it. And then, you get a vaccine and, it could be that, there are these links to some of the brain fog, for example, a little bit of brain fog, a little bit of fatigue. And suddenly you're hyper vigilant and aware, though, that you're like, oh, I'm not hearing as well. But it could just be the brain fog concept or the fatigue from that day. But then you've tuned into it. And the same thing with tinnitus is actually true. Tinnitus is basically at its root, almost like phantom limb syndrome. If you're not receiving, and not all tinnitus, but most tinnitus is this idea that if you're not receiving sound input, that the area of the brain that used to receive that input goes into overdrive. And we become more sensitive to it when we're fatigued, when we're stressed on the body, when we're paying attention to it. It's very much a psychologic concept. Most tinnitus treatment is cognitive behavior therapy, basically. Or getting hearing aids often remove tinnitus because we're giving the sound back to the brain. But that idea of the stressful scenario and what you suddenly start paying attention to is so key in vaccine research, because we just don't otherwise see evidence in these models. And we publishing in the United States, in the world now, is kind of like it's hard, right? The game of academics is publish or perish, right? You have to publish. And so we do see a lot of mediocre studies that have major flaws, and we're not really good scientific communicators. And so you do get a lot of things that come to your doorstep. And I'm not saying that I'm not above this either. We're all guilty of this. We read one study on something and we're like, oh, that sugary drink that I had is going to kill me, right? It's just, like I said before, proceed with caution in everything you read. And I do think there is some reliance when we use the top of the line methods like that and produce major reports in that sense. So, I appreciate, some mutations are possible in some ways, but some mutations aren't always bad too. Like they may not cause hearing loss, but there's no biologic mechanism models.
Thank you. Can you speak to the common experience of music and shows sounding so much louder than the dialogue as we get older? Should we practice tolerating that too as brain training? My husband with hearing aids finds it intolerable, but I also experience it as difficult, even though my hearing seems quite sensitive.
You may not be experiencing a hearing loss phenomenon. Actually, something that is true. I go to the CES, the big electronics show in Vegas every few years to get the latest technology or maybe speak about disability and hearing loss to tech companies. With all the streaming platforms out there and different cable companies and stuff, we no longer live in an era where everybody's playing on the same game when it comes to volume. And it's true that if you switch from Netflix to Hulu to Prime and different shows on these different platforms, and you notice that things suddenly sound louder and softer and the background noises, there's optimization issues now living in this era of digital technology that, you're not making this up. The sound is worse, and we do have sound coming in louder than it should. And some of the companies have even said we've got to figure out a way to optimize the sound, but it would require you to test your own TV and test the scenarios. It's really hard. So, what you're thinking, it might not even just be hearing loss. It could literally be just that music and shows is rough now.
Thank you. And the question is there financial assistance to help cover the cost of hearing aids? Someone else talked about the importance of policy change and advocating. Do those two relate to each other?
Yeah, I would say policy does happen at a state level for financial assistance often. It's usually Medicaid that helps with this. and Medicaid is not universal. I don't know Hawaii's program, and even when there is coverage, it's not always great. So you wanna push for policy at your local level, and then for the Medicare, which is sort of the big thing, that to me is something that it's a domino that has to fall, and it takes an act of Congress. So if we ever want to see Medicare covering hearing care and supporting hearing aids, supporting access to audiologists, that is something you have to advocate for to your federal representatives.
Dr. Reed, I just am so thankful to you for sharing all of this with us, and I'm happy that we've recorded this session and can share it with people afterwards. Your knowledge is amazing, and I know you went over time, and
No problem.
we so much appreciate that. We hope you have a lovely rest of the summer, and say hello to New York for us. A lot of good comments coming in. It is
Good.
very fascinating. Diane, I don't know if you want to say anything on camera for Catholic Charities. We do have other sessions coming up that we'll let everyone know about. Yep, a lot of thank yous, Dr. Reed.
Thanks, everyone.
A
Yes,
lot of
thank you so much. It was very informative, and we had a lot of people really appreciative.
Great.
yes,
I'm very glad. Thank you so much for having me tonight.
it's wonderful to meet you. Thank you.
Thanks.
All right, everybody. Aloha. Have a great weekend coming up, and we'll see you all later.
Thanks, everyone.
Thank
Bye.
you. Bye-bye.